I can tell you firsthand, I've had experiences in trying to deal with providers and negotiate with them. There's a reluctance. It's put a chilling factor on providers' willingness to negotiate better prices because now they're public, and then they'll have their large payers come to them saying, well, why would you negotiate a better rate with a smaller enrollment than we bring to you? And so the large payers are leveraging those conversations vis-a-vis the smaller ones, and consequently you're getting this. The tendency is to get a concentration of just a handful of payers out there negotiating, and when that happens, you don't have a competitive market.
Welcome to ClaimTalk. This is the second part of a two-part episode. So if you did not catch the first half, you ought to go back, make sure that you listen to that one so that you have all the context you need to understand our conversation ongoing here with Ben, Brad, and Cynthia. I want to circle back, Cynthia. I've heard you talk in the past about some of the ways that we are stretching the continuum of life with our healthcare system in a way that's really wonderful and beautiful, because that's the beauty of medicine, is that it gets better. Do you mind speaking to that a little bit to our audience about how, that continuum has stretched quite a bit than maybe even 20 years ago?
Oh, it has. And I think Ben referenced just the aging population and those that are retiring and the longevity. So we are seeing more seniors. You've got that volume. You also have a lot of new pharmacy drugs. You have more cancer. It's more prevalent. So we're spending more cost-wise on cancer drugs. We have the new weight loss drugs that just are a new thing now that we're seeing more and more patients taking, and of course those costs are going up. So there's a lot of continuum of just our premature infants where we have 1 pounders that we never saved in the past. We can certainly have a little 1 pounder, and we see a lot of claims where they're in the NICU for 4 to 6 months. That's a pretty high dollar claim. But again, good things. Technology has certainly changed a lot as far as prosthetic arms and prosthetic limbs, and the technology that just keeps getting better and better, and the imaging of equipment, CT and MRIs, and where you can see, little fine hairs on the infant in utero. It's like things that we just never saw before. So, but it all comes with a cost. And so those costs keep soaring, and I think it's not going to quit, So where do we cap any of that?
Most of the technological advancement in healthcare has been driving cost up. There's very few that are, this advancement is all about lowering cost in healthcare. It's typically about saving more lives, doing more good things, and it's expensive. Think about a robot in surgery. I mean, hugely expensive piece of equipment certainly didn't make it less expensive to do the case. In fact, it typically takes longer to do the case. There's more anesthesia. But theoretically, the precision is better and the repeatability is better for the clinicians. At least that's how they justify using the robots. So those are all examples, but none of it's really driving the cost down. Now, some of it's moving care outside the traditional hospital into lower level of care facilities like ambulatory surgery centers. You see more and more cases that are able to be done there versus 10, 15 years ago. So that helps with the cost side of it, but for the most part, it's driving cost. And to Ben's point, with so many different areas of reimbursement for the healthcare system, fixed or semi-fixed, like Medicaid, Medicare, there are fewer places for the system to cost shift. And that predominantly lands on people like our clients, our health plans or employer-sponsored plans and others. And so that becomes the challenge for the system.
Sure. Do you mind to speak a little bit, Brad, about payer mix, or Ben? Our audience might benefit from hearing about this. So when I am talking about payer mix, I'm talking about the mixture one facility receives in terms of patients that come in holding a private insurance card versus Medicaid versus Medicare versus cash pay. How does that affect employer plans, for example? So if I'm an employer and I have 100 employees in my city and there's one hospital in the city with a lot of Medicaid patients that seek care there, for example, what might that cause?
It sort of depends on, like you said, the market. So if we're trying to negotiate a really good price or a really good agreement with a facility that's in a high Medicaid area, it becomes tougher because they're looking for opportunities to move some of that cost onto the private pay patients. Although at some point, if you have a high enough Medicaid population, now you get disproportionate share funds from the government, so they kick in. So I wouldn't call it a straight line to say in all areas where there's a high level of Medicaid, we're going to have a hard time. It really is provider dependent. And the charge master philosophy varies in facilities and systems. And so you really don't know until you get in there and start pulling the covers back
Yeah.
on the system. The good news is we got lots of data today that we never had with the transparency information. The bad news is that data is kind of all over the board in terms of quality and how thorough it is in reporting, but it's getting better.
Yeah. What do you think?
It's a tax on employers that we did not vote for. I mean, that's what the Boston Tea Party was about, right? Taxation without representation and all of that. So as Americans, we are kind of just at our fabric or at our core, we are against that type of subsidization without our say-so. And again, I go back to the demographics, and the main thing is millennials are in their mid-30s. You don't really start making the most of your money that you would retire on until your 50s. So they haven't gotten their peak production. So the tax basis is not there for the government to pay for the baby boomers that are retiring at $60,000 per day and that are going to be a massive glut on the system very, very soon. So right now it's basically the Gen Xers that are paying for what's left of the forgotten generation. There's a lot of them. They're still alive, but that was a small generation. But then all the baby boomers. So there's a problem there. And frankly, Medicare will be done in May of 2034 with not having any money.
The trust fund.
The trust fund is at zero in May of 2034. It goes to zero. So how do you do that without raising taxes, which is never popular? But if we want to save Medicare and we want to save Social Security, because Social Security is going to be bankrupted about the same time, what are we going to do? We have to raise taxes. And being someone that doesn't like taxes,
Same.
we have to raise. How do you raise revenues? You can't. What are you going to do? So we're running down this path where, healthcare increases on the commercial side are going up 20%, 15%, 30% year over year, doubling every 3 to 5 years. But it's going to get worse because of the demographic shift that we have, where we have an inverted triangle in our country as far as we're going to have a lot more older people than we have younger people and young families that are coming up. But the bulk of the people who contribute to the tax basis are middle-aged. And that's a really small Gen X generation. So that's why we're seeing a lot of immigration. We're seeing a lot of different things that are, trying to make our inverted triangle a silo. And we need to do it, frankly, if we do want these entitlement programs to exist at all. But that's just something that I see coming down the pike that's outside of anybody's hands. Whether you're on the right side of the aisle or left side of the aisle, this is just a demographic issue. And it's going to happen. And so the charge masters are going to continue to go up.
Right.
And then if the government slashes Medicare reimbursement rates again or something, then that's going to just exacerbate the charge master going up, discount off of billed charges, cost shift to employees, bigger gaps, all of those things. So we've got to get to a grassroots movement going to critical mass where we say, okay, let's establish a geographic reference point plus a satisfactory profit margin and go from the bottom up. This current system is complicated, but it is absolutely unsustainable.
Absolutely. Yep.
We have 10 years.
Yep.
We have 10 years before we get to a point where I don't even know what you do unless you adopt some type of bottom-up strategy, which is like what they did in the 1970s in Maryland.
Yeah,
right?
The all-payer system, yeah.
In Maryland in the 1970s, right after 74, when RISC was passed into law, Maryland state government said you cannot charge more than 130% of Medicare. So in all of the states and U.S. territories, the cheapest charge masters is Guam. Number 2, Maryland. But our leadership in Washington did not pattern themselves after Maryland, which is right next door. They went after the Romney Care model from Massachusetts, which didn't work in and of itself on a state level. So let's roll it out on a national level. That sounds like a government issue.
Situation.
Yeah. Right? So it's flawed. The whole system is flawed.
Sure.
And we need to not tear it down and rebuild it, but just modify it so that it's actually something where the middle class doesn't get completely destroyed.
Yeah, right. When I was early in the business, I was really fascinated by how I thought the millennials were going to break ACA. I actually spoke about it at Benefits Pro when I was a youngster, before we watched this dumpster fire sort of happen, because I'm fascinated with how my generation impacts the ACA. I found it interesting that the individual mandate penalty was $650, and someone my age at that time would certainly pay that before we paid a monthly premium to the tune of $650 a month.
Right.
And that was just one little number in the law that I was really quite obsessed with. I also was fascinated by the law. ACA passed just as I was entering the industry, and so it was an interesting time for me because I'm watching brokers who have been in the industry for a long time not really know how to move their feet. And I'm like, read the law. I also, like you, studied it. I got a NAHU certification on it.
Every Friday afternoon at 4 p.m., the supplemental document would come out from Health and Human Services, and I would sit down and read those 30, 40, 50 pages and cry.
Weep quietly and drink
Right.
a cup of tea.
Right. What a great way to end the week.
Really put a cap on it. I would love to hear some hypotheses or some maybe ideas for policymakers or for people in our industry, from everybody at this table, just some forward-thinking tips.
In 1990, there were only 10 specialty medicines, 10 specialty drugs. And let's define specialty drug as designed to treat a specific disease, there's no generic equivalent, and it costs at least $600 a month.
Okay.
There were 10.
In 1990.
1990.
Okay.
Yeah, so when the Affordable Care Act passed, there was like 250. Now there's almost 400. And 80% of the FDA pipeline that's coming to getting approval is all specialty medicines.
Right.
So the drug companies, the big pharma, has realized how they're going to make money, and they're doing quite well with their strategies.
Sure.
But what we've got to do is change a couple of things. First thing is the patent protection of 17 years needs to go away. If I have a magic wand and I can do whatever I want as an executive order, I would put the kibosh on 17 years of patent protections for specialty medicines. Because in Europe, for example, not that we want to pattern ourselves after Western Europe for any reason whatsoever, but let's look at this one specific incident.
Okay.
You can change the molecular structure one little iota. So, and you can roll out a similar drug, right? So it's not a equivalent, it's a biosimilar drug. Mm-hmm. We can't do that in America. We can't just make one little modification and then say, I've got a new product, right? But, I mean, that's how every other industry in our country works. Why is it that, and you can say research and development, but we've all seen the studies where big pharma companies spend 10% on research and development and 90% on marketing.
Right.
So
Right.
that
That's a
R&D
scapegoat that doesn't exist.
exactly.
Yeah, right.
It's the boogeyman.
Yeah,
And
right.
so that is something that we've got to get control of, and because it's quickly becoming, it used to be it was 80-20 rule. 20% of your healthcare plan spend as an employer-sponsored benefit plan was on drugs.
Pharmacy. Yep. Right.
And 80% was on
No longer. Those days are gone.
It's growing up. And then if you talk to the reinsurance markets, so those excess of $1 million in coverage carriers, you talk to them, you say, what's hitting you the worst? They're like specialty medicine.
Period.
And they can name them. They're like, da-da-da, da-da-da,
Oh, yeah.
da-da-da. They're like,
Yep.
they're, $16 million.
Yeah.
Yeah.
Right.
Like, what?
Yeah.
We didn't see $1 million.
And genetic therapies are just coming around the corner that are just going to
Right, gene therapies and,
Yep.
and everything of that nature. So I think from a political position, we've got to get past the lobbyists and get to our senators and congressmen and get something done in the pharmacy to curtail this trend, because it's exacerbating the problem.
Wholeheartedly agree. What are some tips?
So mine's sort of maybe it's a naive, hopeful hypothesis. I eventually think our system's going to get political leaders in place that have the intestinal fortitude to actually have honest conversations about the underlying problem and the urgency of making the change, and then we'll make the change. I don't see that now in Congress. I see a lot of fighting on the edges, and it's both sides are fighting each other. And, if one side comes up with a good idea, the other side's sort of first and foremost going to fight that idea, not because of the merits of the idea necessarily, but just because it's the other
They
side
wanna
saying
win.
it. So
Yeah.
I'm hopeful that we get leaders in place that'll actually consider the problem, the severity of it, and actually move forward on some things that would very much help. And be honest about the cross subsidies, because there are cross subsidies all over in our system, and we pretend like they aren't taxes, and we say we don't raise taxes, but we stick a mandate out there and we don't fund it. And guess what? Somebody in the healthcare system is going to have to pick the cost of that up, whether it's
Yep.
the provider, it's the employer, the payer, the plan, or
patient,
whoever it is.
whoever, yeah.
We try to shield those costs from the taxpayer because we don't have the fortitude to actually square our shoulders up and call it what it is. So there's no doubt that what Ben talked about, we got fewer and fewer people that have to pay for more and more people at a time in their life when costs are going up. I mean, that's the simple math. If we don't recognize that, we're going to see further disparities in healthcare. The haves and the have-nots. There'll be
gap will widen.
That gap will widen, and it won't be on the lines we've traditionally seen or the lines we necessarily think it'll be on.
I know, yeah.
It'll be coming to a town near you.
I know, yeah.
And so, but I also believe that the United States has always been a leader in healthcare. To a degree, we've subsidized the world and we've taken care of the world with innovation, and
Yep.
we'll come through again.
We need to look after number one, maybe.
Yeah, maybe us first, and
America first,
and
you.
we'll bring others along with us, like we have. But,
Yeah.
but I'm actually hopeful.
Yeah.
Again, sometimes hope is not a plan, but
Hope is not a strategy.
yeah, it's not a strategy. but I am hopeful that we'll get the leadership to actually step up to the plate.
I appreciate what you said about intestinal fortitude. I think that is an important part of it, is having those real conversations and being able to say, the number one lobby in our country is healthcare, period. That's what it is. That's what we spend the most of our lobbyist money on. It's also a place where we're bleeding and we're not able to be competitive internationally because we're bleeding ourselves out.
Yeah, I mean, you take 30, 40 years ago, the healthcare lobby was probably a fraction of the size of the healthcare lobby now, and the money spent and the committees. I mean, my first stop after graduate school was on the Republican staff of the Ways and Means Committee in 1993 when the Clinton Reform Plan came out. I was one of 3 staffers on the Ways and Means Committee for the Republican side. So,
No kidding.
And I was fresh out of graduate school. What the heck did I know?
Well, you had ideas and you were probably real excited.
Well, I mean, I was sure. I had ideas and I was sure. That's important. But now you look at the staff and the committees and the infrastructure in Washington around healthcare, it's exploded.
Cynthia, what are your thoughts?
I can't top that. Those are both really, I think pharmacy is huge, the cost in pharmacies. And I always have questioned why. I used to read the Medicare regulations, and it would be the exception Maryland hospitals. And I thought, why is Maryland exempt from all of this? And then I started reading about what Maryland hospitals, what Ben addressed, and it's like, why can't we do that? Why are other states, why did we not adopt what they're doing? We price Maryland claims, and we price it at billed charges because they've capped those billed charges. Yep. It makes sense. Those hospitals have not folded. They're still surviving. They're still working. Why can't we even bring that back to the table and discuss that option?
I wanted to take a moment. We have spoken about ACA at length, but I want to also go back and talk about the No Surprises Act, the NSA. You do yourself some lobbying to maybe adjust that act a little bit here.
Yes.
So I want to hear your perspective and hear you talk about that.
Okay. Another unintended consequences of sometimes well thought out and well intentioned legislation, transparency. We know that our president, Donald John Trump, loves to negotiate and loves competition and capitalism and all of that stuff. Okay, wonderful. The healthcare system, how has transparency affected it, positively or negatively? If you're in the hospital system side, I think it's impacted them positively. If you're an employer-sponsored benefit plan, I believe the Transparency Act has actually hurt you because now all procedures are posted, and so you can look at your competing hospital and see what they're charging for a gallbladder removal and say, oh, they're getting $25,000 from United Healthcare and Blue Cross Blue Shield and Cigna, and we're only getting $12,000. Does that competition, which we see in every other industry in the country, does that positively or negatively affect us as an employer-sponsored benefit plan? It's negative because it's not a consumer product. We don't say, gosh, I want to take my gallbladder out. Where am I going to go to get it done? You know, like you do going to the movies. You're like, I like the recliners at this movie theater better, so I'm going to go there and pay the extra $2 for the ticket price. In healthcare, you don't see that. So that hospital that's only getting $12,000 for gallbladder removal, they're not running billboard ads down on the interstate going, hey, if you have to have your gallbladder taken out, come here. We're 50% cheaper than the other guys. You know?
Yeah.
It's not a consumer product. So what do? They go, let's raise our prices to match what everybody else is getting. And so in urban areas especially, we've seen all of the claims level up since 2019, as opposed to competition bringing prices down, which was the intention of our well-meaning government.
Yep.
I agree. In a lot of cases, the Transparency Act has not created a ceiling for negotiated rates. It's actually a floor. And so the negotiated rates have moved up to the floor level in the market. And so you're seeing that. And I can tell you firsthand, I've had experiences where in trying to deal with providers and negotiate with them, there's a reluctance. It's put a chilling factor on providers' willingness to negotiate better prices because now they're public, and then they'll have their large payers come to them saying, well, why would you negotiate a better rate with a smaller enrollment than we bring to you? And so the large payers are leveraging those conversations vis-a-vis the smaller ones, and consequently you're getting this. The tendency is to get a concentration of just a handful of payers out there negotiating, and when that happens, you don't have a competitive market. You have, markets start doing what monopolies do to markets, and it's not good for the consumer. So, in a lot of cases, I think that's spot on. And as part of that too, when there's a dispute on an NSA claim and they go to the dispute resolution phase, far and away, most of those are decided in the favor of the provider. So
Right.
we're seeing a large percentage of those. Some of those claims, we actually had one that was decided. They gave them a number that was well in excess of the charge, not what they would have negotiated in the market.
Wow,
But
so the
they're actually
arbitrator-
asking for more and
Yeah.
got it from the arbitration.
Oh, my goodness.
So
Okay.
yeah,
We didn't pay it because it's non-binding.
yeah, so we continue to fight that because we think there's some arguments to be made before that gets paid. But having said that, that's, again, unintended consequences. Transparency sounds great, and more data is good generally. And so we're all for that, and we use it, and we negotiate with providers using it. But there are clear cases where it's actually had a negative impact on pricing.
Perhaps unintended.
Yep.
Yeah.
I'm sure unintended.
Do you want to speak a little bit about the binding versus non-binding decision of dispute of the IDR process, please? Yeah.
Yeah, if it's binding, whatever the dispute resolution, the IDRE third party that's evaluating the reimbursement.
Which reimbursement is the right
versus
one?
the proposal from the facility. If it's binding, what they would decide you would have to comply with as an employer-sponsored benefit plan. But as the way the law is written today, the NSA is written, it's non-binding.
Right.
So therefore, it's a suggestion. And because the IDREs want, who initiates these? The hospital systems. So the IDREs are favoring the hospitals so they can keep their cash cow coming, right? There's a monetary benefit to them to appease what the hospital wants
Right.
more often than the employer-sponsored benefit plan.
Right.
So we see that, but so that gives us as co-fiduciary with our plan sponsors, it gives us the perspective of, okay, well, this one's bonkers, so we'll see them in court because ClaimTalk pays for the court costs in the event of a disputed claim that ends up in litigation.
Yeah. I wonder a little bit about how sometimes the law gets written in terms of pulling expertise into the mix to help get us sort of focused in the right direction rather than focusing on whatever lobbyists want to focus on and getting, I'm wondering if that would help us, generally speaking, from a policy standpoint, to have a little bit more seasoned experience in the room where it happens. If it's, I don't know if that would be helpful or if there is a lot of experience in those rooms and we're just having a
No.
hard time coming to agreement.
There isn't. No. There's organizations like the old Health Underwriters, which is now NABIP,
NABIP, yes.
NABIP is a group. SIA, Self-Insured Institute of America, I think could do more. Get more. We should promote them more to get more power and lobby.
Yeah.
To get common sense things added or removed.
Yeah.
From the bills and laws before it gets to the thing. But employee benefits brokers, who are generally the NABIP members, the National Association of Benefits Insurance Professionals, right?
Yep.
There's not a lot of money laying around for employee benefits brokers to send to Washington to a lobby to get something done, in comparison to hospital lobbies and the big pharma lobby.
Yeah.
So
Yeah.
you're going to get outspent 1,000 to 1.
Right.
So that's where it comes down to the hope strategy of hopefully we have somebody come show up in the next 10 years that wants to have a legitimate conversation with the constituency. And given the internet, I mean, think about it, 100 years ago or 120 years ago, they would do whistle stop, stump speeches, and maybe somebody picked up a newspaper, maybe.
And
or
read
maybe
it.
Not, and read it, right? But today, with the internet, communications it's so easy to get to the masses.
Yeah.
We have to have legislators that are having an actual conversation about Social Security's dead in May of 2034. Medicare is going to be gone too. Educate people on the demographics of the country, and then so we all go as a collective conscious, okay, we're going to need to fund that because we want our parents and grandparents to
Absolutely.
have their claims paid, and we don't want everything to run like the VA. We don't even want the VA to run like the VA, frankly. We want to fix that too. So that takes money. And instead of spending so much money on the military industrial complex, maybe we reinvest in our population and make people healthier. I don't know.
Our health is
Seems
our
so
wealth.
logical, right?
Yeah. I want to circle back to something you'd said that I think is important. If Medicare is going to be dead in 2034, I think it would be helpful to have people in the decision-making seat who won't also be dead then.
Yeah.
That's not a slight.
That's not an
I
ageism
appreciate
statement. It's
experience.
not an ageism
No,
statement.
I
It's
appreciate
just-
experience. I'm sitting at this table with you fine people. I'm not trying to be ageist.
You're absolutely right.
Yeah.
But we have to have people who are looking more than 10 feet in front of their face.
Correct.
And 10 years in front of their face.
And the next election cycle.
Yeah.
would be great.
Yeah.
Yeah. Yeah. Well, we've somehow turned this into a political podcast. So forgive us, everyone, but thanks for hanging with us. Thank you so much for being here. I know everyone's inbox is probably at 100 miles an hour right now. So I appreciate you taking the time to sit down with me and have this conversation. Thank you to our audience for tuning in. Please make sure that if you don't already, that you like and subscribe on YouTube, Apple, Spotify, wherever you get your podcast content. If you're on LinkedIn, make sure that you like and follow our page so that you see when we drop this content. We spend a lot of time and energy bringing this education to the market, so we appreciate you hanging with us. And if you got to the end of this podcast, 2 thumbs way, way up.